All right. So this is a little unusual. Most of the time when did the live relay, I was there. But here, Anu and our team, Cath Lab team, is there. And Anu, good morning from your point of view. From all of us here, full house at India Live. We have, I printed uh, various our moderators and commentators all are here with chairperson and ready to see the case and tell us what you are showing today.
Okay, thank you, Dr. Sharma. Thank you, Dr. Matthews, for giving us this opportunity to do the live case. Myself, Dr. Kini, Director of the Cath Lab, and I have Amit Huda, who is going to be, who is our my assistant here, but he's a faculty, full-time faculty here. I have two of my fellows, Sagar, Vishal, our nurses, who is Will, Ashley, and Pablo the tech, and of course our IVUS, which is Kiski. He'll be the one that is teaching us the IVUS. So if you all are okay, I'm going to start showing you the first of the present the case. Can we give the slides?
Yeah.
So this is the case number 32 for you guys. 65-year-old male who had presented to his cardiologist with the exertional angina, and when he went to him, he did a stress test which was strongly positive, especially in the inferior and precordial ST depression. It was just ETT. He had a cardiac risk factors, controlled hypertension.
No, your slide is not being shown. Had to move.
So we have nothing to.
Yeah, good. Now we are there. Yes.
Then we see here the clinical presentation, but risk factor wise, controlled hypertension, hyperlipidemia, diabetes with a SAQ score of 54, which means he does have symptoms. Ex-smoker. So other clinical variables, he had normal EF on the echo and good medical therapy, well controlled hypertension, you see that, and lipids which were there. His LDL is 84 on Atorvastatin of 80 and HDL is 33, and he has been taking Metformin, hemoglobin A1C of 7, and has just been on aspirin. So he came for Cath in February, which revealed 3-vessel disease with a totally occluded right coronary artery. I'm going to show you the angiogram. Significant disease of the LAD diagonal, moderate circumflex disease with a syntax of 38. So knowing that diabetic 3-vessel disease, high syntax score, we took him off the table to have heart team discussion. He had a meeting with the surgeon and then again came to see me last week, and a family discussion, everything happened, and they opted to have a PCI. So I think I'm going to show you the angiogram right now. So EF is normal, EDP was also normal. We are giving a lot of hydration. This is the right coronary artery, totally occluded. We do see some collaterals from the left side. So this is the left picture. So we have a 7 French guide, and there has been some dampening despite having side holes. So if you see here a moderate disease of the circumflex, the OM1, which is diffusely diseased and small size, during discussion with the surgeon, he felt that the vessel would not be suitable for having the bypass. And this is where the LAD you can see here, and the nice RCA collaterals from the LAD also. So the disease starts right from the proximal before the septal. There are, two more moderate size diagonal with a moderate disease about 30%, 30-50%, but significant disease is in the third diagonal, which is involved, and it's a bifurcation disease. And if you see here, cranial picture, but more important, just a dry cine showing speckles of calcium, at least moderate calcium, just on angiography. And this is where we are today, and we did the FFR of the circumflex, which was 0.84. So the plan would be for us to do IVUS guided complex PCI of the left main, LAD diagonal. If everybody is okay, then we will do the IVUS. Yes.
Yeah, because of, this is what remember in the FAME trial also, they downgraded many of those multi-vessels with the FFR. So physiologically 2-vessel, anatomically 3-vessel as clearly circ lesion is at least 70%. Okay, tell us about the calcium is there, but it's like a moderate calcium in the LAD on angiogram.
So I do have a rotawire. So this is the kind of, if you go back, I'll show you the angiogram. If you see here, you want to do direct rotawire, that would be okay. You know what? I wanted to show the, if not, if we think that you want to do over the wire, use a regular workhorse wire because this is not a difficult vessel to wire, and then change to rotawire, that's good. We are going to do IVUS right on the rotawire, and then we can decide. I mean, just based on the angiogram, we decided, and the vessel, that we do have a 1.75 rotabar ready. If anything else changes when we do rota, we will see. And we'll also interrogate the left main as we are doing the IVUS.
Okay, while you're doing it, our moderators, questions you can ask. Dr. Kini.
Okay, we are distal to that lesion. Kiski, can you start and show the IVUS side by side?
Okay, I'll start work. It's coming. Here's a okay landing zone. No calcium. It's coming. Not so much block here. Still distal already. Some blanch. Yeah, some fibrous block. It's coming. Yeah, one quadrant calcium.
So one quadrant there. This is distal to the diagonal.
Tight stenosis.
Yeah.
Some septal blanch. Yeah, 1 to 2 quadrant.
That's at the level of the diag, right?
Yeah. There's one quadrant.
So about
calcium.
180.
Yeah, vessel size getting bigger, like 3.35. Oh, here's a big vessel. Here's also like 360 calcium.
This is
Yeah.
Significant calcium in the proximal LAD.
Yeah. Severe and a diffuse calcified lesion and long lesion. Now come to the big diag. This is the prox LAD. Here's open, patent. Now come to the left main. Left main also has some plaque. I can check the area. Yeah, plaques. Yeah. Now come to the aorta.
Okay.
I will stop.
So there is some plaque in the distal left main. So
Sure.
if you can give us a cross-sectional area,
Sure.
but I think the significant calcium is mostly in the proximal LAD, almost 360-degree arc of calcium. So we have 175 bar. It's not so we can just do the PCI.
So can I
Now?
can I ask Samin, after IVUS, this lesion is good for rota or IVL or for laser? What is your decision?
So very good point whether the lesion, it's the circular calcium. So plaque modification with some decalcific devices will be appropriate. A lot of people, I mean, with what has been shown in this meeting, is a lot of IVL. So I think it's a time to show the atherectomy, but both of them can be used safely. It's a long lesion. Now laser, remember laser is not for calcific lesions. Laser is for instant restenosis, unexpanded stent, and uncrossable lesion. So calcific lesion, many times the laser will not go, will not make the turn. So laser will not be for the calcific. It's usually only for inelastic.
Samin, I thought I was wanting to say orbital atherectomy.
Oh, orbital.
So how do you decide between three in a particular case?
So question comes down to that of the three, orbital, rotational, and the IVL. So I think IVL, many people will use IVL in this situation. Simple, easy, no issue about any complication and so. Some people, we like us, knowing that very good with a rota, as what Anu doing, that select for the rotational atherectomy. But question is, can you do rota versus orbital? I would say that what are the differences? Majority of time you can use both of them, particularly once you have circular calcium, both are very effective strategy, orbital and rotational. Differences are orbital cause little less slow flow. So hemodynamic compromised patients, orbital will be preferred. Second is the tortuosity. Orbital wire is 0.012. So tortuosity, orbital should be avoided. And third will be the ostial, aorto-ostial lesion, where or maybe out, although they say now you can advance and pull back with the dyna assist, but we have not done that technique. but aortosteal. So those are the three group. I would say rota will be preferred. I mean, in two of them, and of course, with the hemodynamic and slow flow issues, orbital will be preferred, but both can be used. This case can be done with orbital atherectomy without any problem.
So, I mean, one point is that the calcium and the proximal portion appears thicker, and the distally is the more superficial. It's a thicker calcium because of the acoustic shadow is more, and it is projecting into the lumen. So, mostly it's a calcific nodule in the proximal portion.
But
So-
I thought on the IVUS, it looks like a more a
Huh?
thick calcium, not the nodule.
Okay.
Keski, was it a calcific nodule
No,
or
no, no.
just was a thick rim of
The
calcium?
proximal portion
No.
of the calcium.
We'll go back to that, but to us looks like it is just calcium, no calcific nodule.
Okay,
Do,
so
do that 360-degree arc of calcium.
yeah, 360, at least 360 calcium, but looks like not protruding a
We'll
lot.
get
Yeah.
IVUS ready to
Yeah.
after do rota. Dr. V.T. Shah.
No, my question was whether this patient is Asian or American. The left main is 4.58. 4.5 is the cutoff. So I was just
It's
interested in
a patient South Asian.
South Asian. And secondly, the calcified circular length is less than 5 millimeter. If it is more than 5 millimeter, IVS, definitely.
So we are doing the rotational atherectomy with 1.75 bar, same slow pecking motion. So we've done the rota of that tightest area right now already. So when they say it's 20 seconds, I'll just stop there. So now I'll go to the point where I just started right there. Yes.
You keep seeing the hemodynamic systolic
Yeah,
pressure
yeah.
always above 100.
I think. I'll try once
one
more.
thing more.
If it's not going to make a turn, I think we'll come out. It may be a little too big for that at the angle.
Did IVUS help her to select the birth size in this patient or not?
That is.
No, you
But
could
I
do
would
that.
say
We'll go back
even
to
without
that.
IVUS,
Okay.
Yeah.
Go back to the
That's
IVUS
something the
exactly
rota
where
will
that where we can tell them how we can select birth size on the IVUS.
Yeah, mid part of the LAD vessel size is 3.5. So now it's birth to artery ratio is 0.5.
I think we did a good right polishing done. We are coming out now.
Yep. So the question basically was that did IVUS
Would the-
help in selecting the bird or would have used 1.5 or 1.75? I think looking at the angiogram, if I'm not using the IVUS, I still would have gone with a 1.75 because calcium was more in that mid segment 1 to 2 o'clock, not very long. If it was very long calcium, this entire lesion would have gone with 1.5 bar.
And
Show us that IVUS.
yeah. I will
IVUS
show you.
is the
Go back to the
circular-
IVUS. Remember, they had a question where in the proximal LAD 360-degree arc, just show there because they had a question if it was a nodule.
It's
Now
not
you see
sticking
that every
inside.
time the guide is engaged, I have a dampening pressure. I have to pull back. I'm going to pull back a little bit. Yeah. Okay. Do an angio. Okay. Ready?
Yeah, there is a small nodule proximal to it, but
Yeah.
that's not a circular calcium at that place.
Give me the run through. Good.
The plate.
So I think now we are going to go with our workhorse wire, which is a run through side by side for the LAD. Now, what is the panel thinking about diagonals?
All right, any questions? Guys? What should be done to the diagonal, particularly the second or third diagonal is a large vessel with a clear lesion at the ostium.
The lesion is extending a little proximal portion also. So I think it has to be addressed.
So the diagonal should be addressed, whether with the knowing that we don't have the drug-coated balloon. This is kind of vessel. It's okay to do a drug-coated balloon, and if Reese knows in the future, you put a stent. But we actually in USA we are just starting the trial, and they're all only for ISR at present. Once the ISR is done, then we go to the side branches and small vessel, or native vessel, I mean. But at present, only for we are starting the
Okay, so Miss Amber.
sirolimus solution.
D2, D3.
Dr. Kini, what
Yes.
are your endpoints of rotablation?
So,
What are your endpoints of rotablation? Do you do
excellent. So,
imaging after rotablation to see if there are cracks or something?
I mean, ideally not. Like I was going to tell you what's the imaging percentage. So we recently have did our analysis, internal analysis. Our percentage has gone up. Maybe like 15% of our cases we are doing imaging. Ideally not. The way we would do here is now your endpoint. So before I started, I did not show you the 3 steps. Very important. We have to make sure we remove the tension from the burr. We do those 3 steps, and then like how I showed you. So the long lesion, it was almost more than 40 millimeter lesion. So you go slow packing motion through all this, the entire lesion. So you will do whatever 15-20 millimeters at a time, and next time when you go, you will go to that 21 millimeter, do the rest of it, and at the end you do the polishing run. So until you have known, you know that you have crossed the entire lesion, you keep doing it. So I did mention that if I was having trouble third time to cross that LAD from mid to distal at the angle, we would have then thought, should we downgrade the burr? But we were able to cross it. So going back to your point, you have to make sure you traverse the entire vessel. And once you're done that, you will do your polishing run. Do we ideally do IVUS after the rota? No, down. So this is what I think of we will teach you without imaging. How could you do? I think we will do imaging after this. That this is a high pressure balloon, 3O. So we always say go 1:1 vessel size would have been the IVUS is telling us 3.2, right, at the distal.
Yeah, so actually start of the
But we
program
have a 3O. So you went up to 22 atmospheres, and you see the vessel, the balloon has nicely expanded.
Yep.
If we had seen the balloon had not expanded, this is the time you can either image again and see, or you could decide whether you want to do IVL or cutting balloon at this time. So now this is where the tight, see that calcium, even that has responded.
Mhm.
We can do the imaging now. Any other questions? Ready?
And I can tell you that, remember, we always want to do imaging after that's a rota. But who has the endpoints that this is done? This is enough rota or enough atherectomy, and we should do it more or less. Clearly,
Just before opening the device, let's just look at the angio ones. We'll just look at the angio ones.
Yes.
Okay.
Hello.
yes.
Yeah, hi, this is Dr. Ajay from India Live. My question is to Dr. Kini. In long calcific lesions like this, the size of the rotabar you decide based on distal vessel or the proximal vessel?
So interesting question. I think not distal vessel, proximal vessel. It is burr to artery ratio, which will be 0.5 to 0.6. So if you take this vessel, if suppose I'm saying we did not IVUS here, right? We did not IVUS. Angiographically, it's close to 3.3, right? It is close to proximal, probably 3.5 LAD, distal probably 3.3. So you go 0.5, right? 0.5 is 1.5 burr. So that will be the distal vessel. But then proximal 3.5, that's why we went. Proximal LAD has the highest calcium even on the angiogram. That's why we went 175. The second point was, it was not tram track and not severe disease. If it was 90% tram track 40 millimeter lesion, you downgrade because you're going to cause a lot of debris as you're doing IVUS. As you're doing rota, which will cause slow flow. So those are the two things. So this was almost like a significant disease, very short, which somebody mentioned earlier, maybe 10 millimeter lesion proximally in the proximal LAD. So that's okay. You go bigger burr, and then bigger burr means 0.5 to 0.6, and because it's a short lesion rather than if it was a longer lesion. Did I make it clear?
Yeah,
So
thank
I
you
think
very
the
much.
point is still is very clear to always for the rota teaching. Just go with a small burr. We don't need to, because particularly now we have other adjunct devices. You're cutting balloon. We're actually doing a study called Rota Cut, where I'm saying burr to artery ratio is 0.3. Don't even go further, because when you have complication of rota with the bigger burr, so, and if need to be, IVL is there. So cutting balloon, IVL, so no need to go to bigger burr. And we are actually looking at our data that has a rotational atherectomy. We do about 60 rotablation per month. Of the 75 atherectomy we do, of the 325 PCIs, about 22%, 60 are rota,
I'm
about
trying to go to the other branch.
12, 13 are orbital, and 3 are Lesion. So that is how our 75 number per month is. So key is that whether advent of IVL, avoiding the bigger burr, has decreased the rota complication. So we are actually looking into that aspect.
Down. So that is a very interesting point Dr. Sharma pointed out, that your question is same. I think nothing wrong. Everybody should get 1 fiber, and later on you decide. Now you have so many other adjunct devices, IVL, open NC balloon, cutting. So then you can decide which one. In the past, I think even with the cutting balloon, we used to have problem, but I think now IVL is taking care of it. Okay. So we did atherectomy to the side branch, which is always we teach, because non-aorta ostial also could be significant, the ostial lesion. So this is a 225. Go back up again here. So we are going 16 atmosphere to make sure, see that? It's fully expanded. Once we have done this kind of angioplasty, there's a dissection of the vessel, and I think it's better we stent it. What does the panel think?
So actually they want to see the picture. I would say that let's take the
Okay.
boat, because this vessel
Good.
is looking little smaller, 2.2.
Okay, fine. We'll take a picture.
Knowing that the drug-coated balloon is not available, after the cutting balloon, you want to leave it alone, stent across, or you do a 2-stent approach there.
Okay.
But let's take a good picture with the nitro. Give nitro first. All right, let's take the opinion of our moderators, and so yes.
Okay.
Maybe
they'll
one
say-
question more. See, these diagonals don't make a difference in prognosis ultimately. What you want is actually that it should not close during the procedure. So what I'm asking you, that is there any role of FFR after dilatation of the main vessel, whether it to touch the diagonal or not?
So question is, remember, there have been a few trials have done that we used to do a side branch FFR and so, and like DK Crest 6, they looked into it, that we did multiple FFRs, overall outcome was not different. So I say that side branch intervention should be guided by your clinical, means you see a decreased flow, patient has chest pain, some EKG changes, or your 90+% blockage, or for the left main maybe 70, then you go after. Because FFR by and large will be negative. We learned that. And therefore, and there is a randomized trial. Remember the DK Crest 6 was looking into this aspect. Can you decide side branch based on the FFR? And answer was, lot of work was done, lot of dyes was used, and FFR outcomes were no difference at all. So I think
Problem with the diagonal is they are ostial lesions. Dilating with a balloon, simple balloon, is never adequate. Either it will dissect or it will be some kind of optimal dilatation. So as far as possible, my thinking is that we should leave it alone rather than taking, committing that you have to do something further. After the stent, believe me, it will look very tight again. Believe me, it will look again tight, then you will leave it ultimately.
So the question basically is that even if the 70-80% lesion, Medina 111, if the vessel is 2.25 or so, should you leave it alone rather than intervene? So that is one approach.
Yeah, so I
Nothing
think
wrong with that.
point is that that vessel is bifurcating down, and there is a good branch going
It's a
down.
good size.
So the area of supply is larger. So I
Okay.
think that vessel has to be protected.
Okay, Anu, tell us what is your thought process here? A lot of opinions here. And strategy.
No, yeah, I agree with all the discussion that has happened. The way I normally like to approach this is, if you want to intervene, right, just balloon angioplasty and say leave the side branch alone is not an option, because one, it look bad. Two, there's a risk of this vessel closure later on when he goes out, which is not good. So if we think we are going to not touch the side branch, then I would say no touch technique, leave it alone. Just stent across, but that decision
That
should
is
be
what
made
we
in the
want.
beginning.
That's what you want.
But now we
No, but there was a
decided.
tight disease.
Yeah. Now we decided there's a tight disease. We went, intervened. We already dissected the vessel. I think now we need to stent it. No point deciding to.
Everybody says yes.
Okay. So we'll go.
What
I think.
strategy?
I mean, of course, we love mini crush. That's what we are going to show. Mini crush, right?
Okay.
Yeah.
Okay.
You get us a 16, right? 2 to 5, 16. So we will show you our apps
LED
in the side. LED.
Put the app on the side and LED, you have the longest synergy.
Yeah, that's what we have. We have a 48, 3 of 48 synergy. And then we'll go 2 to 5, 16 to the side branch.
So
What do you want?
If we put the proximal reference
right.
after the
Yeah.
D1, 38 is enough to cover the lesion.
So Kiski is telling me, based on the IVUS, he's telling us if we stop where at the level of the first diag?
Yeah, just after the first diag to the distal reference is 38.
No, he's saying just after the first diag, if we stop, we can do it with 38. But I think based on my visual assessment, we need 48. What do you think? Huh? Right? There is a little bit, there is some plaque in the distal left main which we want to avoid.
Yeah.
What is the distal left?
To cover the left man.
We are not planning to cover the left main. How
Actually,
much did you get?
distal left main area cross section
What was
5.5,
the
but
MLA of distal left main?
5.5 I'll show you.
He's getting 5.5.
like that. But we know it's a FFR negative. We did FFR today to the circ.
The distal left main is 5.5.
No, I think Kiski, you can go a little bit outside.
Yep.
Yeah.
Yeah.
Go out a little
Here's
bit.
a
Yeah.
kind of like
No.
attenuation.
I would
Yeah.
say it's go 6. You have to go a little bit
It's,
outside.
7 French guiding and ostia is damping. Pressure is damping. So obviously we have to call from the ostia left man.
Then
No, but
question is,
ostial left main does not have disease.
Yeah,
No,
ostial
there's no
left main
disease
doesn't
in the
have a
ostial left
disease.
main.
Yeah.
No,
Definitely
look at
open.
this.
Ostial left
Yeah.
main.
Ostial
Definitely
left
open.
main is very nice.
Yep.
It is just
Why
like
don't
the
you-
question was asked, the patient has a small vessel. That's it.
Why don't we do IVUS now to decide the landing zone proximally? Why don't we do that?
Okay. Is that what everybody wants? Quickly.
Yeah.
Give the IVUS.
That's quick.
Okay, let's be.
Yeah. So actually, you know what? The lot of people just go to the ostium, bring the stent back up to the ostium. That is a prevailing
Yes.
concept nowadays. The cover it.
But
We actually, I would say that if there is no beaking, if dampening is happening because of the proximal to mid, not the ostial left main. Remember, anytime you bring to the ostium, it will be projecting outside. Always will be a trouble in the future. It can cause the trouble. If ostial little beaking, then yes, you should do it. But ostial is clear. Just
Go.
Stop short of the ostium.
Okay,
That is what
I'll start to back.
also important, this
Coming, this
patient,
means
circ
already-
is not revascularized. The knowing is diabetic. No matter we are doing good medical therapy, will be more aggressive with this lipid management. There's a risk that he may develop a circumflex disease in the future. So we
Yeah, I
need
see
to
that
have
this
access to
plaque.
that.
I'll come to the plaques LED.
You see some cut.
Yeah, I see some hematoma. Yeah, this is a good plaque modification.
Okay.
Yeah, and the diagonal. Yeah, this was the 360. Yeah, I see the fracture and the much bigger lumen. And come to the plaques LED. And here is the D1. Yeah, still on the plaque. And before the D1, it's yeah.
Oh,
it's
there
true.
is a
It's
good
full
landing
vessel.
zone.
Then it's 48.
Yeah.
What is the area
Yeah, and
there?
this is the left main. Yeah.
So give him the proximal
stop.
LED cross-sectional area. And that you're saying is 48.
We are all interested with the left main
Sure.
MLA. That
MLA.
Should it cover left main or leave the left main alone?
Okay,
I would
so
say
now
in
I
this
see
case,
the yeah. This is the circ
Yeah.
from 9 o'clock. I go to proximal. Yeah, around here. This is the left main.
Okay, good.
Yeah, they're there.
Yeah, like this.
Yes.
Yeah.
because this case will going to need a circ PCI. I can tell you in next 1 or 2 years, despite negative FFR.
Yeah. Like same.
Just
Like
5.5,
around. Yeah.
Less than that.
then should cover it. I think you need to bring it to the mid left main.
Right.
Left main need to be
Yes.
covered in this one.
Very focal.
I think 48 will
Right,
cover it.
everybody, all our.
I think 48
Alright,
may
guys,
not
what
cover
do you
it.
think?
I think.
Yeah.
Yeah.
I think we put 38 then, if you have to. And then we put a
All right,
different
let's
one.
take care of your stent first.
No, so no, we are very important 48 versus 38, because if we are saying left main, we have to go 38 and put a different 48 may not cover completely, right?
So basically, what it's saying is that let's cover up to the ostium of the LAD with a 38, and then do the FFR to decide whether left main PCI, left main stent should be done. Yeah.
No, that's a good question, but you have to remember we did already FFR from the left main to the circumflex,
True.
which was negative.
Right, which was negative.
Yeah, yeah.
So which was negative.
Yeah,
So there
okay,
is a
we'll do
chance
that.
this
We'll do
will be
that.
Negative.
Yes, I think it will be negative also. I did tell our team here that they likely will ask us to do FFR for the distal left main. Okay, give me the 38 quickly. So we are going to put a 3 or 38 in the LAD and stop in the proximal LAD where there's a nice landing zone.
Yep.
And then we'll be doing FFR. Have the FFR ready.
Okay. I can tell you it's a very good idea because this is in between. Lot of intermediate. We talk.
No, then we go back to the LAD. At that time, we'll go back to the LAD, not the circ.
Yeah, exactly.
FFR.
Right now, 38. Remember, 48 otherwise come. We give few millimeter gap from the left, this, and then you do overlap. You don't want to overlap. at
Can
the
we put
origin.
remove the IVUS and put the mini crush side?
It did one time already, yeah.
Just I want to ask, this case is a dominant RCA
Okay, give me some.
and which
time.
is total. It would have been safer to take care of the RCA first, then touch the left system.
So good point.
Because if something goes
This
wrong
is
in
side
the
branch.
left system, it's totally shut down of the coronary
die.
circulation.
Some die.
So as you saw, the left, the right coronary has a very
Good.
the particular J-CTO score is 4. This question comes. We wanted this patient to go for surgery.
He said
Let's say
left
if
main,
you
right?
have right patient, you revascularize left system
Okay,
fully
now die. Of
and
the,
remain
some
with
die.
the RCA closed. I think
Okay,
that's
good.
okay.
Side branch is
It'll
good.
be all
Some
right
die.
because
Side branch.
RCA chances of success are very low. You saw the RCA,
Go.
very blunt system,
Okay. Where
and
is
very
happening?
proximal branch only.
Yes,
Maybe
go.
retrograde approach. There was no good retrograde collaterals either.
Okay, good.
So
Go
it
up.
could be
Side
done.
branch.
And of course, we have a lot of CTO experts can give on this. But the idea was that we left system revascularize.
Down.
We'll try
Go up again.
RCA.
2 to 5
maybe
they
by
give,
the
right?
retrograde approach, integrated, no chance.
Okay,
And
down.
if you only fail, leave it alone because this is the patient who are referred for CABG after
Some die.
discussion came back for percutaneous intervention.
Okay, good. Go up. With the, yeah, go up. So you're
But
watching
that's
the
a
mini
very
crush
important
technique
point
there.
because you want to
Yes.
revascularize
Yeah.
fully.
Okay, go up. So we placed in the proximal LAD where there was a nice, yes. Down. Go up again. Give me a 2O balloon to recross.
Dr. Kinney, we have what, 5 minutes? We're extra by about 10 minutes now. So
Okay, so what I will do is I will do the FFR of the LAD because recross kiss, I don't think anybody would like to know that. We can do it offline, right? We'll do that because that's probably more interesting.
Yeah, that's a good idea.
Yeah.
Let's show the picture and do the FFR because then we go off because you have 5 minutes now.
Good.
You see,
Give the
balloon has to
FFR
be
wire.
done. But that's a later
That
stage.
will be done.
But what we need to see, okay, now let's take the bet. PT Shah, FFR positive or negative? Negative. Positive. Let's
Who is
see.
saying positive?
Sharma.
You have it?
No, he's not American. Patient is not American. No.
Height, weight, BMI.
Oh, height, weight, BMI. Give him, please.
They can tell us the height, weight, and BMI.
Guys, get us a height, weight, BMI quickly.
On the Cath report.
Oh, we are here. BSA we have. No, not the BMI.
No, BMI. You need BMI Cath report. It's on the Cath report. Remember,
Okay, give me the
second page on
FFR.
top.
Okay, good. Ready for the FFR. We have rewired it. All we have to do is kiss balloon. Side branch has been rewired with the same fielder wire that was sitting in the guide.
But have you shown the picture? Can we take one cinema?
Okay, okay. Good. Give you a picture. Ready?
Nice.
Nice, good, Darsan. Good.
Let's do the FFR. And remember the FFR fallacies which were shown earlier by Davis. This one guide has to be come out. Once you
Okay, guide is,
engage
yeah,
the
yes,
wire,
we'll do that. Pablo, ready?
No, but that was a lot of discussion today.
Hello.
Where's the? Yeah.
You have two wires there, you know.
LED wire is out.
Yeah.
That's okay.
Why did it come out, guys?
Three wires would be.
Okay, good. You want me to remove the diagonal wire?
I think.
Okay, go, show.
No, but remember this one you had to equalize before. Remember outside the left main.
Yeah.
These guys don't have a torquer here. Hold on. It's too
I
bad.
know. But remember.
Okay, but it's a before. It's a before now. Yes. Okay, go, equalize.
Still further back.
I mean, how could it? What is this? Okay, equalize. Can you see it now? Yeah, good.
Yes. Okay.
Okay, good.
Good. Okay.
Guys, I mean, how could you make this? How did you take out the torquer?
Take the LED wire out, but
Okay. I don't understand why. It's already positive.
wire distal guide out. Start your. Just show it.
Start the adenosine, guys. Oh, it's already 0.83. I think it'll be positive.
Disengage. Okay.
I have disengaged.
All right, guys. What did I say?
No. Disengage. Totally disengage first.
It
No
is.
IFR? Do you have
It's
IFR or you don't believe?
it's in the iota, ascending iota.
Guide is disengaged.
No, this is not Renju. Okay. So RFR.
Adenosine has been.
Which company? Correct. No, they have not.
Yeah, same.
Adenosine.
No, adenosine is going. Started
It's only
long time
50,
ago.
60 seconds.
We would have seen RFR also with the same wire. This is a bot wire, I think so.
No, this is the St. Jude's, which is Abbott.
Yeah, but so we would have checked the RFR also.
Remember, in the two things you need to do: guide out, and your wire has to be all
Americans
distal.
believe more in FFR.
Pardon?
Oh man. 1.5 minute now.
But it started with 0.83. Remain at 0.83.
We didn't want to stand the left main.
Yeah. See, the tracing is good. But that time, as I said, the guide was partly engaged. That's why. Now it's already gone. No, equalization was right.
Yeah,
It's
yeah,
only
it was
during
right.
wiring that it went. Yeah, equalization was right.
Okay, I think we have to decide now.
think
It's
we should
already
leave
2
it
minutes.
now.
Yeah.
You start pulling back that, once there's question,
Okay.
you can always pull back, that
Yeah.
you become equal.
Yeah, let's see. Let's see whether at that point you get a step up or not.
Yeah, you do. Yeah, it's
Yeah.
one. Yeah, it's one.
Yeah, you
It's
do.
it's beautiful.
Yeah. And now see, it's one. So therefore, there was no fallacy in the recording.
Right, exactly.
Yeah, you got it one again. That's fine.
Okay, so we'll
Excellent.
just do the
With that
kissing
note,
balloon.
Okay.
Yep.
Yeah.
And we just conclude what you need to do, and we completed our time. Thank you.
Okay,
Yeah,
good.
thank you very
And
much.
okay, yeah, congratulations.
to the full team. Yeah.
Thank you.
To the full
And-
team.
And also congratulations to Samin Sharma, our boss, who is getting the Lifetime Achievement Award later. We won't be there, but you
Oh,
have all of
yeah.
us there spiritually.